one to the femur, one to the tibia. There are 4 markers in each. There are 4 in here. This is a marking tool, bone mapping tool. Then 4 here, 4 here. There are 4 there on the robotic arm also. Then there are 4 here, and all this, everything, all these markers from a mesh, which helps the robot to navigate through the space. And they are so sensitive that even if patient coughs or breathes heavily, like deep breathing also, that is also detected. That movement is also detected by the robot. If at all patient coughs, the robot will stop immediately. Less than a millimeter movement is detected by this robotic system. So that is how the accuracy and everything is achieved. So just to cut down on time, we have already fixed the marker and we have fixed the leg to the robotic arm. These pins, they help in fixing the leg to the robotic arm so that there is no movement. And whenever the robot is cutting the bone, there is no movement of a bone, and cut become absolutely precise, and there is no deviation in what we have planned and what the robot is doing. So we have done a lot of when I started robotic, I was very apprehensive that whether the robot will cut accurately or not, whether there will be any errors or not. But whenever I used to take the bone cuts, I used to verify it with the verifying tool that the robot was saying that it has cut 7 mm, whether actually it has cut 7 mm or not. And we have done it for many hundreds and hundred joints, and the accuracy is sub-millimeter. If it says 7 millimeter bone cut, it used to be somewhere around either 6.9 or 7.1. So that is less than a millimeter variation is there. So that is how the accuracy, accurate alignment is not good. The life of a knee replacement goes down. So when we do a CT scan, after that we get this kind of image showing. So this is how the data is generated, and then go to femur implant. Femur implant. So this is how the implant looks, wherein we can see how it is fitting, whether it is accurate for the size of the bone or not. And we can just move around and see how is it fitting, whether the angle and the diameter of the anteroposterior diameter as well as mediolaterally, whether it is there is any overhang or not. You can see in this image also that we can see how well the implant is fitting on the bone. And then the size of implant and everything is decided on this CT scan. And initial start. So this is the initial final information which it gives, that DISTM, distal medial, that tells how much the bone is cut on the medial side distal. So that is 6.6, that means 6.6 millimeter. Okay. Then DISTL, distal lateral, 8.2, posteromedial, posterolateral. What is the angle? What is the extension angle? Then is there any varus or not? All this information can be decided before doing actual surgery on a patient. So we are actually doing a virtual surgery before performing a surgery on a patient. So it's like you're making a 3D bone model and then doing the virtual surgery on that bone model. And then that final plan is executed, confirmed during the bone mapping, and then executed on the patient. So we'll go to bone mapping now. So these are the points which we have to take on a bone.